Good afternoon, everyone. Welcome to this session on critical systems thinking. I'm Nikki Jobson. Before I hand over to the two presenters, I will just cover a couple of bits on housekeeping. Mike, if you could do the next slide, please.
Problem there, and it's not.
Do I do the next slide? I haven't got control.
There we go.
Thank you. We recommend, so that you can see both the speaker and the slides at the same time, you position the speaker in the top right hand corner. You can, if you have any particular issues, you can use the chat function to send us messages. If you use the Q&A function in the menu at the bottom, that's where we will be collecting the questions for the Q&A session at the end. So what's going to happen is we've got a single presentation with two presenters. Mike will open up with an introduction, followed by Lewis, and then hand back over to Mike again. So what we're going to do is hold all the questions until that final session has finished. So you can write your questions in that Q&A menu at the bottom. You can also vote for questions. So what I will be doing at the end of the session is looking for those questions that have had the most significant interest in them. And then I'll put those towards both of our presenters at the end. So hopefully we should have about 20 minutes questions at the end. There may be some polls that pop up. However, that will only happen if you've not accessed it via the browser. We are recording this session and it will be available after the session. And also what we'll also be doing is recording the questions so that they can be looked at after as well. And it may well be that Mike and Lewis will be able to follow up some of those questions. We do have a hard stop at 1400 because the next session follows hot on the back of this as well. Okay, so I would like to introduce Mike to kick off the presentation, please.
Okay, thanks, Nikki. And welcome to everybody to this critical systems thinking talk in the systems stream, which is called Lessons from the 2014 Ebola Epidemic for UK's response to the COVID-19 pandemic. Lewis, my co-speaker, is extremely well equipped to talk on the 2014 Ebola epidemic, because at that time he was leading the local response as the Director General for the World Health Organization in Africa. And he'd also been a PhD student in critical systems thinking at the University of Hull, so viewed it through that particular lens. So he's going to kick off by talking about the Ebola epidemic and response that was made to it. He'll then talk about the challenges that were posed and what went wrong from a critical systems thinking perspective. I'll then look at what lessons might have been learned from that Ebola outbreak that might have led the UK to do somewhat better than it did in response to COVID-19. And then finally come on to what insights critical systems thinking has about Ebola and COVID, and indeed what it can learn from COVID and Ebola, what the insights it itself can learn from them. So I'm going to pass straight on to Lewis for the first part of the talk, which is the Ebola epidemic and response.
Thank you. Thank you very much, Mike. First of all, I would like to greet all participants to this event and this session in particular. Also to thank the organizers and chairs for the opportunity of participation. And of course, Mike, it's a pleasure to participate with you for this presentation, for this talk. I'll start sharing my experience in leading the regional response to the Ebola outbreak in West Africa in 2014. As you know, Ebola virus disease is a zoonosis a disease transmitted from animals to human beings, and is highly virulent in humans. About 22 million people are exposed to the risk of Ebola, particularly in humid and rainforest areas across Central and West Africa. You will realize the red dots are representing the Ebola virus disease outbreak since the first time in DRC. Next, please. Next slide, please. Hello. I'm asking for the next slide. I don't know if I can change from here. No. I'll provide you some background. In 1976 was the first case of Ebola recorded by History of Public Health in Democratic Republic of Congo in Yambuku village that is close to a small river called Ebola. And simultaneously, it appeared in Nzara, another village in Sudan. And since the first outbreak of Ebola in '76 up to 2013, the WHO has recorded 25 outbreaks of Ebola, with a total number of 2,388 human cases, including 1,590 deaths. The 2014 Ebola outbreak started in the forest area of Gekudu in Guinea in December 2013. And the epidemic went unnoticed until March 2014, when WHO was notified by the government of Guinea. And then the deadly virus spread fast within Guinea and across borders up to the capitals of neighboring countries, Liberia and Sierra Leone. And afterwards went beyond this area to Nigeria, Senegal, Mali, Spain, USA, and UK. And let me remind that the case in UK was related to a female health worker that was a volunteer working in one of the Ebola treatment centers in Sierra Leone, and was notified to WHO in December 2014. Next, Mike, please. Here, I want to illustrate the transmission of Ebola virus from animals to human beings, and to say that the reservoir of the virus are the fruit bats, a certain type of bats living in these forest areas of Central and West Africa. And then the bats infect other wild animals like chimpanzees, gorillas, monkeys, antelopes. And the first human case starts with the infection by an animal. And then once the first human case appears, it is the index case, we have a sequence of transmission from person to person, also called human-to-human transmission, that usually occurs in health facility where adherence to infection and prevention control measures are weak, or where protective personal equipments are not available. If the transmission human to human also occurs in communities through contacts among relatives, friends, in mass gatherings, or even people caring for ill, and at the occasion of rituals, cultural or even burials. So this is the way the Ebola is transmitted from human to human in a very fast speed. Next, please. Now, I want to highlight that some economic activities, such as mining and timber industry, can increase the risk of outbreaks if appropriate measures are not taken. This is because of deforestation, because of the construction of roads and corridors, construction of labor camps, and other facilities that induce migration to new settlements. And this can result in fragmentation of the wild habitat, bringing wildlife closer to human settlements. And also some of the rodents and non-human primates will have new food and new possibilities of habitat close to human beings. And this environment, of course, will increase the risk of pathogen spillover from animals into human populations. Next, please. The key phases of the epidemic, just to highlight. Oh, you know what happened. We had the onset of the epidemic in 2013, as I mentioned, and the declaration of the epidemic was only in March 2014 because of the very weak disease surveillance system in Guinea. And the epidemic was declared by the national authorities of Guinea, the Ministry of Health, jointly with the World Health Organization office in Guinea and in the African region. The second phase was when the Director General of WHO declared the epidemic as a public health emergency of international concern. This was in August 2014. At the time, the epidemic was recording 1,848 cases and 1,013 deaths. The next important phase was when the Secretary General of the United Nations declared that the Ebola epidemic was a multidimensional public health crisis. This was in September the same year, when the number of cases were doubling every 3 weeks. And he called for participation and involvement of the United Nations General Assembly and even the Security Council. Then in January 2015, we realized the decline of the epidemic, and the epidemic was over in January 2016. Next, please. Here we want to illustrate. You will realize in dark blue is the curve of epidemic relating to Guinea. In red, in Liberia, and in light green, in Sierra Leone. And the epidemic started in Guinea, and then the second country affected was Liberia, and then the third one, Sierra Leone. In total, we had 28,631 cases, 1,049 health workers amongst them. We had 11,315 deaths, and amongst them 335 health workers during the duration of 2 years. Next, please. Here to highlight the social impact of the epidemic at individual, family, community, and national level. Just highlighting at individual level, the death, the stigma, the psychological impact in survivors. And also at family level, some of the families lost important part of their members. Some of them were completely wiped out. At community level, we had an expression of fear, denial, and even resistance of people to participate in the response. At national level, was really the panic, fear, insecurity, and disruption of the social and economic life. Some of the activities that were programmed for the period, like sports events, cultural, and other mass gathering events were postponed or even canceled. Next, please. The economic impact of the epidemic was also very, very important and highlight the reduction of mining and timber operations. It was a very important source of income for the countries. Disruptions in air travel and tourism, including difficulties to get the logistics to fight Ebola by air, because most of the flights were canceled in direction of these three affected countries. Decline in investments due to panic, declining public confidence and pull out of investors, and poverty rate that was increased in the three countries. And it's important also to say that travel restrictions, quarantine and lockdowns may have led to lower productivity, food shortages, deterioration of fiscal revenue, while increasing the public health expenditure to cope with the epidemic. So countries were really facing very difficult situations. We are talking about poor countries. In the right side, you can realize how the number of visitors in Sierra Leone was declining throughout the period of the epidemic, and the food prices were increasing in the graph that is below. Local rice, oil, and fish were increasing price because of less production, and this was really constraining for populations. Next, please. Here, I want to highlight that WHO proposed to affected member states Ebola response plans according to their own specific context. And these plans were counting on the support of key partners, not only WHO, but other very important partners from the UN family, bilateral partners, and other international cooperating agencies. The response plans had key main objectives: to stop the outbreak, to treat infected people, to preserve stability, and to ensure essential services. Tracking and tracing case and safe burials were very important to stop the outbreak. Community engagement and behavioral change, case management and availability of hospital beds and staff were also very important in managing the health services to treat infected people. Also, to preserve stability was a major concern, ensuring the essential commodities, transport, fuel, social mobilization, and the basic services, not only the provision of routine health care, but also ensuring security, food, nutrition, and also incentives for health workers, and ensuring the recovery economic activities. Next, please. Here, we want to highlight the framework of response and say that these are the key areas of interventions: behavioral and social interventions, clinical case management, epidemiological investigation, surveillance, and laboratory, logistics, and of course, the social communication through the media to keep people involved, as well as the international community, and also make sure that the ethical aspects were really taken into account in the interventions to respond to the epidemic. Coordination was important, was key, but was also very much challenging. Next, please. Now I will talk about the key challenges, starting with the fact that this epidemic was a real multidimensional public health mess. Starting with the statement by Mr. Ban Ki-moon, at the time Secretary General, it said that the Ebola crisis was no longer just a public health crisis, but has become multidimensional with a significant political, social, and economic and humanitarian and even logistical and security dimensions. And that no one country, no one organization had the resources to stem the tide of the Ebola crisis. And there was a need for countries to come together within the United Nations, and he was calling for member states to join the efforts of response. And in my view, the local environment had some very important drivers of the epidemic. First, the context of political instability, poverty, and reconstruction. These three countries were going out of very serious civil unrest. Secondly, very poor health and social and economic infrastructure in these countries. Also, the fact that the epidemic started in a forest area, in a very remote village that was very close to the border of other two countries. In terms of population, it was an area of a very high density and mobility of population within and across countries. The ecosystem was also not favorable. It was a forest, but where deforestation and fragmentation of the wild habitat was taking place with economic activities, creating new settlements for human beings. Urbanization was also very poor, particularly in the areas of mining, industry, and timber activities, because the new settlements were very poor and were not enough protective in relation to the wild environment. It was very close. There was also a time of business opportunities in the context of reconstruction of these countries, and the gold mining and timber industry were really flourishing. Live animal markets and human consumption of wild animals like monkeys and bats was also something that was driving or favoring the occurrence of epidemic. Without forgetting the cultural practices and the religious beliefs, sometimes increasing the vulnerability for infection by Ebola virus. So the problem was lack of holistic view of the epidemic by stakeholders, despite the vision shared by the Secretary General of the United Nations. Next, please. The lack of effective technologies was also challenging because at the time, there was no specific medicines, no specific vaccines for Ebola virus disease. And we had to rely on primary prevention in the context of weak community adherence. We had also important challenge relating with the laboratory capacity. The biosecurity level 4 laboratory was not available in any of these countries, even within the African region. And the samples had to be sent outside to be analyzed. And this was really cumbersome and taking too much time and delaying appropriate response to the epidemic. Next, please. In terms of epidemiological surveillance, we had challenges in dealing with the pathogen dynamics because of very weak disease surveillance systems in countries that required active surveillance at community level, health facilities, and at border entry points. And in a context where the epidemiologists and other staff trained in epidemiology were not enough to do this type of job. It was also difficult to set up a track and trace system for case detection and follow-up of contacts. The very high mobility of populations in rural areas and cities and across borders was also very challenging in relation to follow-up of contacts. Being a zoonosis, of course, it calls for an intersectoral and interdisciplinary approach, one health approach to address human and animal health. And let me say that the coordination between the sectors in charge of human and animal health was really weak or almost inexistent. Next, please. Here, I want to highlight the challenge related to fragmented leadership and tensions among stakeholders. As a WHO Director for Africa, representing my organization, we had within our mandate the role of overseeing the response, resource mobilization, partnership coordination, providing norms and defining standards for action, communicate and report about the event, and tackle the outbreak in support to national health services. We had to deal with technical, financial, and logistic aspects, and even go beyond our mandate of getting involved in the implementation aspects. And the key challenges were related with the coordination of global, regional, national, and local efforts, managing the interface between governments and global stakeholders, lack of fair decision-making processes and frustrations in dealing with the power structures, stimulating government leadership, intersectoral action, and community approach was also difficult, even within countries. And of course, building consensus around national response plan with government officials and international community was not easy. And of course, we had to establish a sub-regional coordination center for Ebola response, an initiative of the regional office of WHO for Africa, with support of headquarters, but that was later on discontinued because of the creation of the United Nations Mission for Emergency Ebola Response, ENMIR, that was based in Ghana after the decision of the United Nations General Assembly about the involvement of the United Nations at headquarters in this response. Next, please. Here, I will highlight the issues related to health system infrastructure and logistic challenges, shortage of resources in general, manpower, money, technology, and also weak management capacity of the national health services, particularly at the local level, where problems occur, and problems of organization, communication, and control, non-compliance with international health regulations, as established by the World Health Organization since 2005, a non-effective logistic chain for medicines and supplies, and weak road and transport infrastructure. Next, please. Here, the socio-cultural barriers and community resistance. In a nutshell, to say that traditional and religious beliefs and practices sometimes were compromising the quality of response. And the issues were related with denial and misconception in relation to the virus and the disease and the way of transmission, and hiding of infected people by people, violence against social and health workers, and as I mentioned, unsafe practices related to culture, unsafe rituals, and unsafe burials. And of course, avoiding mass gatherings was also constraining for politicians that were interested in their activities. In one of the countries, they were going into political elections, religious gatherings. We were also at the time of very important activities for Muslims that constitute about 90% of the population in Guinea, where the epidemic started. Sports events, we had the African Soccer Cup that had to be suspended because of the epidemic. Next, please. And here I want to summarize the challenges and what went wrong. First, to say that these are some of the system issues that I could identify during the response. The multidimensional public health mess exhibiting general complexity. The challenges is that health systems of affected countries were not designed to deal with general complexity, turbulence, uncertainty, and diversity. And I believe that critical systems thinking could help because it relies on the different systems approaches while recognizing the strengths and weaknesses of each one of them. And also, critical systems thinking considers a flexible combination of relevant methodologies. So we missed the opportunity of doing better in coping with the epidemic in terms of its complexity, because it was highly complex. Secondly, the lack of effective technologies. We were not prepared. No available medicines and vaccines, no access to relevant laboratories, lack of hospital beds. So it was really a very difficult fight without the relevant and required tools. Thirdly, the epidemiological surveillance concerns to deal with the pathogen dynamics. We were running after the virus rather than anticipating and preventing the damage. With a limited capacity of laboratories for testing and ineffective contact tracing of a very mobile population. So I think that modeling and probably complexity theory could help in addressing this challenge. Of course, we applied the existing knowledge in epidemiology and public health. It was not enough. Fragmented leadership and tensions amongst stakeholders was difficult to manage because everybody wants to help. And I believe that it was not easy, neither for WHO or for governments to coordinate so many stakeholders willing to help. And systems, soft systems methodology that could help to promote collective leadership and consensus among different stakeholders. Weak health infrastructure and logistics. The main issues were related with organization and also adaptation to local contexts. And I believe that a viable system model cybernetics, and also other approaches like system dynamics could help in addressing these issues. And finally, I want to refer to the challenge of social cultural barriers and community resistance, in relation to which I think that approaches used to cohesive complexity like critical systems heuristics could be used to stimulate dialogue with local communities disadvantaged by power and knowledge, and make sure that they were involved in the decision making. Because the fact that people were not adhering to some of the recommendations was because they were not consulted, they ignored about the importance of the proposed measures, and in some cases they were just driven by other beliefs. So the dialogue was very important and was not enough. But I'm sure that Mike Jackson will provide more in-depth insights on the power and the relevance of critical systems thinking and related methodologies to tackle public health complexities such as Ebola virus diseases, and also the current pandemic that we are facing of COVID-19. So thank you very much for your attention.
Okay, thank you. Thank you, Lewis. I'll be very quick to try and leave time for some questions. In many ways, this is the main point I want to make, is that Lewis has identified the Ebola crisis as a multidimensional public health mess. And I think COVID could be identified as the same. According to Edgar Morin, there are two ways to react to complex situations of this kind that get out of control and start to become chaotic. The first is to treat them as cases of restricted complexity. And that means remaining within the epistemology of the natural sciences, as he puts it, and to use computational modeling techniques to aid prediction and control. Now, I guess that would be something like system dynamics or something like agent-based modeling, or indeed the epidemiological models that were so to the fore at the beginning of COVID-19 in the UK. But the problem is that those models require specific inputs, and we didn't know how many cases there were, what the transmission mode was, what the rates of transmission were. And so as chaos theory tells us, the models were producing all kinds of different results. Add on top of that, the psychological and sociological factors involved, the way people reacted, the way that government reacted to the models, the way that people reacted to government instructions, and treating it as a case of restricted complexity meets all kinds of difficulties. Not hopeless, but it meets all kinds of difficulties, which in Morin says makes it inappropriate for this kind of situation. And as Taleb and Bayam wrote in The Guardian, it was a bit like messing about trying to refine your statistical models when an avalanche was heading in your direction. So it's necessary to treat it as a case of general complexity, according to Morin, the division of these types of approach, to accept the ambiguity of the causal webs involved, and the importance of the epistemological, cognitive, and paradigmatic aspects, he says. And what he means by that is the way that people themselves react, how they view it, what tools and techniques and which perspectives they bring to bear in trying to tackle an outbreak, an epidemic, or a pandemic of this kind. So the lesson from Ebola is that you treat these kinds of things as cases of general complexity, not restricted complexity. Now, taking Lewis's categories, which he drew from the Ebola outbreak, had we applied those to COVID, we might have looked at it as a kind of technical resource issue. And in those terms, undoubtedly, a lot of the parts that would have led to an effective response were missing. There was a lack of hospital beds, of PPE, and of ventilators initially. There were staff shortages in the health service. Microbiology, virology labs had been closed. And so we didn't have a lot of the parts necessary. And a lot of the processes were not in place that would have allowed us to cope with such a pandemic. There were no adequate arrangements in place for track and trace, or no workforce trained for that. If we look at another perspective, organisational structural factors, there was no learning from SARS or Ebola in the way that other countries had, South Korea and Hong Kong, for example. And it's arguable that the response to the pandemic was much too centralised. And you can compare there the approach in the UK to the approach in Germany, where things were much more decentralised. That led to government proclamations met with incredulity because they really did not know what was going on in the regions, in the other areas, and local bodies lacking the authority and information to launch their own initiatives. There was a lack of variety in the response, therefore, because everything was handled from the centre and there was no autonomy locally to react to what was going on in the particular areas that local bodies were concerned with. The second spike in Leicester was a case in point, where it was very difficult for local leaders to get information that was necessary for them to take action, even if they had been able to take action. And of course, the tracing and tracking system was a wholly centralized function when it was introduced, and apparently with little consultation. And as a result, you're seeing the effect of that now with people having to travel hundreds of miles to try and get the tests that they wanted. You could also, again, drawing upon Lewis's insights from Ebola, see COVID-19 as a cultural and political issue. Were we thinking right in addressing it? There was inevitably an element of English exceptionalism, as there always is. Our track and trace system had to be world-beating. Our app had to be unique. We failed, it seems, to listen to the World Health Organization, to learn from elsewhere. There was, I'm sure, groupthink around the science, a kind of establishment science, where they were tinkering around with models. Look at the bickering that took place around face masks. There was constant refining of models. There was behavioural science input, but behavioural science, of course, is the type of social science that is most easily incorporated into traditional science because it adopts a response mode. Government undoubtedly hid behind the science. It had its own political agenda. And one factor that is difficult to talk about, because we're all in the UK at least stuck with it, is the myth of the NHS. You can't gain power in this country without talking up the NHS, how good it is, how you're going to be the main protector of the NHS, and continue to supply it with endless resources. So the mantra became at the beginning of the COVID pandemic, save the NHS. Now, if that doesn't look odd to you, it looked extremely odd to everybody in every other country who asked questions such as, what about those who are ill that you should be saving? Or what about the general population? In Joel Midgley's terms, the NHS was regarded as sacred. It had to be saved. And that meant that other areas were neglected. Care homes, for example, became profane. All kinds of results came from this. There was quick abandonment of track and trace and in favour of making the curve more shallow as it grew. Care homes received less attention for PPE, and hospital beds had to be emptied of people back into care homes without proper testing because the NHS had to be saved. There are also issues around poverty and inequality that Lewis alluded to. Surely we should have known that the poorest would be hardest hit and prepared for that. We should have recognized that BAME communities were among those, and there's suggestions that systematic ageism led to a degree to neglect of care homes. There's a really interesting article in The Guardian today about a bus driver in London, and I think bus drivers in London had the highest rate of deaths, more than frontline health workers. And his case is worth reading about if you want to see how the poorest were treated as part of the pandemic response. What insights can critical systems thinking provide? We've got to approach pandemics of this kind as cases of general complexity where social and psychological factors are involved. We've got to take a pluralism of perspectives on them, and we need to use a high variety of different systems, approaches and methodologies to deal with their different aspects, to use them in combination to bring about multidimensional improvement. Taking each of those cases in point, we've known about general complexity for a while in systems thinking. Rittel and Weber called it wicked problems that it threw up. The planner who works with open systems is caught up in the ambiguity of their causal webs. A still further set of dilemmas posed by the growing pluralism of the contemporary publics. General complexity resists universal truth. You're never going to be able to produce an epidemiological model, a system dynamics model, an agent-based model that provides you with an overall understanding. All attempts to get to grips with it will be partial. And therefore, as Moran said, it's the nature of those partial attempts which is crucial. How are we looking at it? How are we engaging with it? How are we perceiving it? And how are we seeking to address it? We need, therefore, to look at it through a variety of powerful systemic perspectives. And summarizing what Lewis said about the Ebola epidemic and what I said about the COVID pandemic, these would be the systemic perspectives you would adopt. You can look at it through a machine technical perspective, an organismic perspective, a cultural, political perspective, societal, environmental perspective, and an interrelationships perspective. The issues coming from each of the first four being bound together in sets of interrelationships. And these perspectives are not flukes. They don't arise from nowhere. They're experiential gestalts which have proven useful to human beings in addressing problems that arise in social reality. We're then in the fortunate position in systems thinking, as Lewis pointed out, to have a variety of systems approaches and methodologies that respond to those different experiential gestalts. So if we want to address the organismic aspects of a problem situation such as the COVID epidemic, we could use the viable systems diagnosis to look at the problem of centralization, versus decentralization. We could address the cultural and political issues using soft systems approaches, the societal environmental issues, who's excluded, poverty, which communities are suffering most, using critical systems heuristics. And the interrelationships perspective using is capable of being tackled to a degree by system dynamics. We have to take all these different perspectives, these partial understandings, and the systems methodologies and approaches which are relevant to them. Here's a very quick view of what that would mean. Explore the problem situation, the pandemic, COVID-19, from the different systemic perspectives. Use an intervention strategy which takes advantage of the variety of systems methodologies. Intervene flexibly, whatever comes to the fore as most pressing, use the approaches relevant to that, and evaluate how you're doing, again, through the variety of different perspectives that are proven useful to the human community. So the claim of this talk that Lewis and I have done is that the UK could have learned better from the experience of the COVID Ebola epidemic. It could have understood its multidimensional nature. And if it had done so and looked in preparing for a pandemic like COVID-19, If it had looked through the different perspectives, it would have been a position better to prepare for COVID-19 and had more success in responding to it. And the theoretical point is that CST, critical systems thinking, with its broad range of perspectives it takes to this kind of issue, or well-formulated perspectives that they are, and the range of systems methodologies which it knows the strengths and weaknesses of, is in a position to give us a better understanding and a better response to general complexity. And if we'd taken that line, we might have done better in Ebola, combating Ebola, and indeed in preparing for and combating the COVID-19 pandemic. Thank you for listening. So I tried to be quick, so we've left some time for questions.
Thank you, Mike. Thank you, Lewis, for very interesting presentations. We've had some questions submitted via the Q&A function at the bottom of your screen, and I will read out the one that has the highest votes so far, which is from David Lowe. It seems clear that systems thinking would have been beneficial in both cases, but how do practitioners gain access to enable this application and provide advice? I am especially thinking about achieving parity or near parity with traditional science-based advice.
Shall I have a go at that, Nikki?
Yes, please do, Mike.
It's an excellent question to which I wish I knew the answer. And I thought not many months ago that things were improving. A number of us were asked by GoScience, the Government Office for Science, to prepare a handbook on systems thinking, which would have looked at the different systems approaches and how critical systems thinking might coordinate those approaches. And there was, as a number of us know, a systems unit established in the Cabinet Office, which I think lasted approximately 9 months before it was abolished. And let's not speculate who was behind the abolishment of it. But those two initiatives seem to have fallen by the wayside. There is a big task on getting these alternative ways of thinking given equal respect to the traditional establishment scientific mode of thinking. I could go on about the golden triangle of London, Oxford and Cambridge, but I'll leave others to speculate. But it is indeed a very important issue.
May I add something?
We can hear you, Lewis, yes.
Oh, yes. No, it's just to add that, in fact, it's a very important question. And just to add my views to those of Mike, is that, in my view, I think that the public health practitioners and managers, I think that they need to gain knowledge about systems theory. And this would improve the management aspect of the public health responses, while keeping the traditional scientific knowledge to address the biomedical issues that remain important. It's just a matter of adding this dimension. And I would like to refer to a research paper that was recently published by Mike and myself, entitled Health Systems Research and Critical Systems Thinking, the Case for Partnership. It's published in the Wiley, in the Systems Research and Behavioral Science, and those who are interested, they could check our arguments based on the current status of health systems research and systems thinking theory.
Thank you, Lewis. Could I move on to the next question now? From Anumata Ora Singh. I apologise if I haven't quite got the pronunciation of that name correct. It seems decision makers, governments and large institutions have their own agendas in place which make it difficult for systemic solutions to be implemented. What might be the fastest and most effective ways of bringing awareness about systems thinking to the people who are genuinely invested in resolving such crises as COVID-19?
I think it's not just the, it certainly is the decision makers, and it helps them to hide behind a science which they can regard as the science, as they constantly kept calling it. So you have a kind of establishment science, and government with responsibility for decision making tends to try and rely upon that, that so-called establishment science. But it's not just decision makers, it's those who are advising government that have positions to protect. Lewis mentioned that research paper that we did recently, and what we did was to examine health systems research, and it talks, there's a lot of discussion about systems thinking in health research, but it's extremely limited in terms of the types of systems thinking it embraces. So you'll find that almost all health systems research these days are talking about embracing complexity and having to deal with complexity. But then they go on to address it, as Moran would say, by taking it as restricted complexity. And their tool is almost always system dynamics. Which is fine, but there are very few cases because of the number of variables involved, the social psychological factors, reflexivity of people reacting to what things happen, how things are developing and happening. They can't be incorporated within, or difficulty within system dynamics models. So all other types of systems thinking tend to go by the wayside. And those people, I'm sure, in health systems research are protecting their own backs. They've built careers upon that form of thinking about health systems research, and want to protect that and their knowledge and their careers from challenge. So it comes back to the same as the first question. How do we establish systems thinking, this kind of systems thinking with its whole variety of different approaches to complex problem situations on a par with traditional scientific thinking?
Thank you. I'll just try and squeeze in one final question from John Ryan. In his presentation, Lewis mentioned that both SSM, soft systems methodology, and the viable systems method as approaches to modelling the developments around the second Ebola outbreak. Could he say how effective he found these techniques, please?
Thank you. It's a very important question, but I should make it clear that at the time I was already trained in systems theory and in position of leadership, of course. But the environment was characterized by very high pressure from different stakeholders. And the epidemic itself was also escalating. And I had no staff trained in systems theory. I was alone in this discipline. And also I would not really have time to apply in a systematic manner the different methodologies, either soft systems methodology or other. So what I used, it was the insights to better understand the problems and drive my own position of leadership in advising the different stakeholders and people under my leadership. And I believe that this could be more effective in an environment where we work in terms of preparedness, so that when the epidemic occurs, we are with a team prepared to act according to the different methodologies. So we are still working in gaining more insights in terms of practice, and we are looking for opportunities to participate or work with national health services or health organizations to share critical systems thinking views, insights, so that it can be really used in a team rather than an individual.
I'm afraid we're going to have to draw that session to a close now because we've hit our time. So I'd like to thank Mike and Lewis very much for thoroughly interesting presentations. The questions have been recorded. and will be sent to Mike and Lewis. And I'd like to thank all our participants for turning up. Thank you very much. Goodbye.
Thank you.
Bye.
Bye-bye.